All right. Thank you, Dr. Van Hill, for answering the extra questions we had. Our next talk is Dr. Colby Fernelius. His lecture is sponsored by Ogden Surgical Partner, Ogden Regional Medical Center. So if you're associated with Ogden Regional, please stand up. Yes. Awesome. Well, thank you, Ogden Regional. We appreciate you sponsoring. Okay. Now, Dr. Colby Fernelius was born and raised in Weber County. After completing undergraduate studies at the University of Utah, he attended the military medical school in Bethesda. So we got another military here. Colby completed a residency in anatomic and clinical pathology at Madigan Army Medical Center in Tacoma, Washington, after completing a fellowship in dermatopathology at the University of Colorado in Denver. He served as pathologist in the Army in various parts of the world, including Germany, Hawaii, Georgia, and Washington. He also completed a medical education fellowship at the University of Hawaii. He is excited to have returned to his roots to Utah and Associates of Pathology and continues to serve in the Army Reserve. So thank you so much for your lecture and thank you for your service.
All right, I'm excited to speak to you today about, and honored also to, it's something. This is a topic that's very important to me. It's somewhat difficult. I like to compare it to type 2 fun. You might be familiar with different types of fun. It comes from a background of outdoor sports. So type 1 fun it's fun while you're doing it and fun afterwards. So it's like skiing, pickleball, water sports, things like that. Type 2 fun is not fun when you're doing it. It's really grueling and difficult, but afterwards you look back on it and it was fun. So think maybe a 50-mile hike or a marathon or mountain climbing. So I'm hoping this will be at least type 2 fun. So not fun while we're doing it, but looking back on it, it might be fun. Actually, did I get a clicker? Is it this thing? Oh, green, okay. All right, so I don't have anything financial to disclose. Some of the things I'm going to talk about, the grading of atypical nevi is a little subjective though, so some of these things will be my own opinion. We'll go over these objectives. We're going to talk about the importance of evaluating pigmented lesions. We get skin biopsies of pigmented lesions from every specialty. And so I'm hoping that it's applicable to all of you. We get pigmented lesions on the genitals from the OBGYN clinic, from ENT when they find a pigmented lesion close to the areas they're working on. And anyone can submit a pigmented lesion. I'm going to talk about the nomenclature and classification, especially of atypical lesions. You might get a report that says the diagnosis is a compound nevus with cytologic atypia and architectural disorder. And what does that mean? Is it mild, moderate, severe? So I want you to have a better understanding of what those things need. And I was going to talk about the optimal biopsy techniques. Yesterday, the brilliant, innovative Dr. Osman showed an AI-prepared video of biopsy techniques. And so it's the first example of AI making my life easier and possibly replacing me. So I was really fascinated by his lecture. And it was all done in a British accent, so I can't compare with that. All right, so everyone has moles. Everyone has a constellation of 12 or so moles on their body, sometimes many more. Sometimes they can be considered a burden and maybe something cosmetic that the patient doesn't want. Sometimes it's a beautiful or distinguishing feature, a flower in the garden of life, and people have used cosmetics to add a mole to their face at some points in time. Moles are present in the most average person to a very recognizable person. And so even Pope Leo you can see a mole on his upper lip. So the most recognizable person in the world right now. Everyone has moles. And we're not worried about the moles that everybody has. Sure, irritation and cosmetic reasons could be a reason that we get mole biopsies, but we're worried about when these moles go wrong, and when they have atypical features that merit evaluation by you all. And so that's an important thing that we're going to look at. From the pathologist point of view, we'll get a mole that is completely benign looking, a compound or intradermal nevus. And it's easy for us to make that diagnosis. It doesn't take a lot of time. That's one spectrum. The other spectrum is a melanoma. And again, when the features are frankly malignant, this doesn't take us a lot of time to make this diagnosis, but it creates a significant impact on the patient's life. And then there are the lesions in the middle that don't quite meet the criteria for melanoma, but are not just a common or average nevus. There's something going on, and so it's our job to describe what's going on, and that can take a lot of time, and this is the part that can become subjective. There's a little bit of controversy on how to best treat these and follow these up. So that's what we're going to talk about. And this is the point where people might start looking at their neighbors, at their moles, or their own arms, and wondering what's going on. Okay, so the reason that we worry about pigmented lesions is because of melanoma. We live in Utah, and we are blessed to have or cursed to have the highest rate of melanoma in the country. It's not hard to understand why. We've taken a big chunk of people from Northern Europe and placed them in a very high altitude place with a lot of sun. People from Utah have relatively long, healthy lives, and so they accumulate a lot of sun exposure over the years. In addition, we like to be outside all seasons of the year, and we just get tons of sun, and that leads to our high melanoma rate as compared to other parts of the country. Melanoma is an increasing cause of malignancy in younger people. And it's just important to remember all those risk factors, histories of sunburns as early on in life, and lots of sun exposure, immunodeficiency states, all these risk factors for melanoma that we're familiar with. And that's why it's important. We still see tanning beds around town. It kind of makes me cringe when I see these. I don't think all the tanning beds are being used to treat atopic dermatitis. And so there's risk factors all around us. Okay, so we may ask, where do melanomas come from? Are melanomas coming from the moles that we have? And there's lots of studies that have looked at this, and they've found that anywhere from 7 to 75% of melanomas are associated with a nevus. I mean, what does that mean? And the problem is, when a diagnosis of melanoma is made, there's no requirement to report whether there's associated nevus or not. So that's kind of the old data. Newer data is saying that anywhere from 20 to 30% of melanomas have an associated nevus with them. And I think the important thing from this data is that we need to monitor long-standing nevi in people and the changes that a nevus may encounter quickly or changing over time. That's an important part, but it's also important to recognize changes that happen in previously normal skin. So there's those two things that we need to look at so that we catch melanoma as early as possible. Okay, so in a perfect world, there would be a precancerous lesion that we could look at for melanoma, and it would be easy to detect. And I think of what we learned about this morning with the adenoma carcinoma sequence in the colon. We know that in colonic mucosa, as it undergoes genetic mutations, it results in an adenoma. An adenoma is the same thing as saying low-grade dysplasia. And then with more increasing genetic alterations, it turns into high-grade dysplasia or a high-grade lesion. And then as it progresses with more mutations, it turns into superficially invasive cancer, metastasis, etc. So there's been people that have looked at this, Shane et al. Back in 2015, micro-dissected melanomas that had associated in situ areas, intermediate atypia areas, and benign nevi also, and then even normal skin. And it sought to look at all these genetic changes all in one lesion. And sure enough, if you go from the normal skin all the way up to a melanoma with metastasis, you can see that there's increasing numbers of genetic alterations. There's markers for increasing UV damage and specific genetic targets that happen all within the same lesion. And that would be great if we could kind of decide on what this precancerous lesion is, but there is no precancerous lesion when it comes to atypical nevi. We found that nevi with mild and moderate and even severe atypia can be stable over a lifetime. So there's not a precancerous lesion when it comes to melanoma that's easily recognizable clinically. So now we're going to talk about those atypical lesions and the difficulty in their diagnosis. So you've probably heard me say a couple things. I've said atypical nevus. We've heard the phrase dysplastic nevus. There's all these kinds of names, and that contributes to what's called the Dermatopathology Tower of Babel. There's just all these different ways that people are communicating atypical nevi. In addition, there's lots of lesions in disguise. You can, for example, you can have a Spitz nevus that the cytology is similar to a melanoma, except we know that Spitz nevi are completely benign. There's nevi that occur at special sites on the scalp or in the milk line or genitals that can have microscopic features similar to melanoma. So it makes the diagnosis of these atypical lesions and melanoma, these borderline lesions, very difficult. So I'm going to kind of establish some basic features that we can hopefully all become familiar with and agree on. So clinically, you're looking for a lesion that has an irregular border, asymmetry, changes in color greater than 6 millimeters, and is changing over time. And this is what we can call an atypical nevus clinically. Then microscopically, we look at three main categories, and this is where it can get kind of subjective. We're looking at cytologic atypia, whether the nuclei are enlarged and pleomorphic, so there's a variation of size and shape. We're looking for mitotic figures, so that's a marker of whether these lesions are proliferating more quickly than normal. A melanoma many times has an increased, although subtle, proliferation index that we can look at. And we're looking at the architecture of these lesions also. So under the microscope, is there asymmetry? Do the nests at the dermal epidermal junction start filtering outward and expanding quicker than the dermal component? Are the nests merging together and confluent? Are the nests going down adnexal structures? Are they percolating up into the epidermis, which is what we call pagetoid thread? These are all things that we're looking at along with a host response. Has the body detected an atypical clone and the immune system is creating a response to with fibrosis or scarring or chronic inflammation? So you can see there's multiple things clinically that we're looking for and a lot of things that we're looking for microscopically. And that can help you understand why some of these things are hard to classify. And that brings us to the nomenclature. So remember, type 2 fun, okay. There's been several consensus conferences to try to come up with an ideal name for what we're talking about. And the problem is that it's not universally adopted everywhere. Now, I've been able to see reports from this area, and I think there are some things that have been adopted. So I'll say what I believe is the best nomenclature. So the clinical term, when you see these changes, call it an atypical nevus. I don't like the term dysplastic nevus because to me, dysplasia is a step along the path to malignancy. And atypical nevi don't always become melanoma. In fact, they're mostly stable over a lifetime. Now, the microscopic term that you're going to get on a report is going to call it a nevus with cytologic atypia and architectural disorder. And it's just the best way to confer all the different changes that we're seeing. And then we'll grade it usually as mild, moderate, or severe. And just know that mild lesions are stable over time, and there's not much that needs to be done with those. Severe lesions, there can be some overlapping features with melanoma. So we'll consider that a little bit more. The microscopic diagnosis doesn't really roll off the tongue, I admit. You're not going to see patient support groups for nevi with mild cytologic atypia. You're not going to see it on a bumper sticker, mild atypia and architectural disorders. You're just not going to see that. So I admit it's not perfect, but it's a way that we can convey all the different features that we're seeing underneath the microscope. And so it is difficult, but we do have some help with difficult cases. So one thing that is shown to help is dermatopathology training. Because pathologists, the skin is readily biopsied, so pathologists are very used to seeing lots of skin, and they become really good at evaluating skin lesions. But that dermatopathology training has been shown to help in these difficult borderline cases. So it's important to know if your pathology group has some dermatopathology training for these difficult cases. And also get to know your pathologists. Just picture them alone in the basement of the hospital, no windows, a microscope and tons of slides, and they're just waiting for you to call them and talk about your cases. And nothing they would love more than to speak with another person. So we also have immunohistochemistry. These are special immunohistochemical stains that we can use. They're not perfect, but they can help and push us one way or the other. I use a key 67 that is useful for the proliferation index. If we can't see mitotic figures, key 67 will stain cells that may be about to go into the mitotic phase, and it can give us an idea of the mitotic rate. There's lots of stains that will highlight the lesion so we can get a better look at the architecture. And there's a new stain, somewhat new, called PRAME, P-R-A-M-E, that has been found to stain melanomas and usually not stain atypical nevi. It's not perfect, but it can be useful in difficult cases. Then there's consultation. I'm always happy to share difficult cases and get a second opinion or a consult. The more eyes on a lesion can be very useful in difficult cases. So that's an important thing to talk to your pathologist about, is consultation at places that see a lot of difficult cases. I think that's important. And then other tests such as a 23 gene expression profile, I've seen that give a lot of useful information in these borderline lesions when it's not easy to excise or there's a lot of question in the diagnosis. Castle does a 23 gene expression profile that gives great information. Okay, so biopsy, when and how. Just remember to communicate with your dermatopathologist and that dermatologists are the most adept at knowing when to biopsy these lesions. But if you become comfortable with seeing the clinical features, then it can lead you to be comfortable when to biopsy and when you can wait and watch a lesion. Not all patients can get into a specialized screening area, so it's important for us, everyone, to know about these clinical features. So the macroscopic criteria, know those, the A, B, C, D, and E. You should be very comfortable with that. If it's not your thing, there's other criteria that you can use. If you want to add math to your evaluation of this, you can use the Glasgow 7-point checklist. And it assigns numbers to different major and minor criteria. And once you reach a certain number, it can lead you to biopsy. And there's always the ugly duckling test. Everyone's nevi should be fairly similar on the individual patient. And if there's one lesion that sticks out, then that could be an area that you could consider biopsy. Okay, so now the biopsy methods, those have been covered very well, I think, in areas of this conference. I just want to give a shout out for an appropriate shave biopsy or a scoop biopsy. When I want to look at the entire lesion, an appropriate shave is the best way to do that. So if you see your lesion, make a 2 millimeter margin around it on the normal skin, and then if you shave that lesion to the reticular dermis and submit that, I'm going to be able to see the breadth of the lesion. A punch biopsy of a pigmented thing, I wake up in the middle of the night wondering what's going on at the edges of the punch biopsy. So people have been worried that they're going to transect a melanoma when they do a shave biopsy. But if you do an appropriate shave, then studies have actually proved that these lesions aren't upstaged on subsequent re-excision. So get comfortable using that flexible blade and do an appropriate shave of these atypical lesions. And we're happy to look at those. Okay, now the treatment. And this is a little bit controversial. So I'm going to read a statement that was in the leading dermatology textbook when I was in training. So this is from Bologna. If lesions are slightly atypical, no re-excision is recommended as long as no residuum of the nevus is clinically apparent. If lesions are moderately atypical and present in the margins, even when no residual lesion is clinically obvious, a re-excision with clear margins might be considered. It should be emphasized that the latter guidelines are based on the author's experience and may not be accepted by other colleagues. So that there's a lot of opinion in those statements. Now, with increasing data over time, we know that even mild, moderate, and even severely atypical nevi are stable over a lifetime. And so the question is, when should you re-excise these? I just read a paper last night in preparation where someone recommends re-excising severely atypical nevus, not because of the potential that they could become melanoma, but because of the potential of a mistaken diagnosis. So because there's overlap in the features of severely atypical and melanoma in situ melanoma, that it's worth re-excising severely atypical lesions for that. So this is my opinion. It may not be accepted by other colleagues, but if something is mild or moderately atypical, that tells you that the patient needs regular screening. So take a look at these persons' moles over time. Refer them to a dermatologist who's set up to do regular skin checks and map the person's moles with photography or other methods. If there's severe atypia and it's present at the margins, then you should consider a re-excision. And you can talk to colleagues, dermatologists, about whether it needs to be re-excised. Consider the patient's clinical and family history. Does this patient have history of lots of sun exposure and sunburns over time? And that you could consider re-excision for these lesions, but not always. If this person has a lot of similar clinical moles, then it's very likely that it will be stable over time. And you just need to focus on the lesions that are quickly changing, and you see rapid growth or change. Those are the lesions. And then, of course, diagnosis of melanoma in situ and melanoma, clear guidelines on re-excision with appropriate margins. Okay, so just to summarize, you have a patient with a pigmented lesion, take an adequate history, and do an appropriate clinical exam using those macroscopic guidelines that we talked about. Use the right algorithm, and then do the appropriate biopsy, a good excision, or an appropriate scoop shave. That's what I like to see. Then understand the pathology report and what it's meant by mild, moderate, and severe atypia, and consider whether this lesion needs re-excision. And then know that the more atypical nevi that a patient has, they're at a more increased risk for melanoma. So educate the patient on the need for evaluating their moles on a regular basis. And that's the appropriate follow-up. So to summarize, pigmented lesions will continually be important in this area, especially because of where we live. Screening may not be as important in areas with less frequent melanoma, but where you live, melanoma is important. So it's always going to be something to keep in mind with all of your patients. And there are useful tools that your pathologist has to go to, and appropriate tests and understanding the report. Call your pathologist, talk to him if you don't understand. So that's all I have. I can take questions now.
Colby, I have a question for you. I know there's some dermatopathologists that try and lump all their atypical nevi into kind of low grade versus high grade atypia. I'm not sure if that's where you are with that. I do love what you said about. I mean, I think a good scoop shave biopsy is great. It's happened a lot where a punch biopsy has been done by a primary care doctor, or just a partial shave of a lesion, and they call it severely atypical. Then I go back and excise it, and they say, well, actually, this is melanoma. I think you did a good job of showing, a bigger lesion can have kind of both features. Yeah. But I guess my question is, high grade versus low grade, is that where you try and lie? And
well, you can definitely be more reproducible in your diagnoses if you have fewer categories to lump things in.
Sure.
And so I think if there's good adherence to a more uniform program like that, then I think that's better. And I would actually recommend fewer groups to lump things in. Especially because they can be so stable over a lifetime.
But I do love how you mentioned the fact, with colon cancer, these are precancerous things. Yeah. These atypical nevi oftentimes are not. Right. And so a lot of patients will say, oh, I had a pre-melanoma. Actually, you didn't. You had a mole that was really goofy, but wasn't enough to pull the trigger and say this is a cancer, and it probably will not proceed. So I appreciate you saying that. Thanks, Colby.
Okay. All right. Thank you.